Perfect. So my name is Nicholas Kwok. I am an MIT and Harvard Medical School alumnus, a faculty member at Harvard Medical School, and a doctor of internal medicine. I currently practice hospital medicine at Beth Israel Deaconess Medical Center. I created MoleCheck together with Dr. Jessica Wu, a dermatologist and faculty at UCLA. We were one of the winners of the Global Appathon. So first, I want to give you an overview of this talk. So I'm going to talk about the difference between moles and melanoma and the epidemiology of melanoma. Then I'll talk a bit about the screening of melanoma and survival in melanoma. And then we'll talk about the features of MoleCheck and the front end and the back end of MoleCheck. And then I'll show a demonstration. And then finally, we'll talk about the limitations and next steps for developing MoleCheck. So we built MoleCheck to triage moles for the risk of melanoma. But what are moles? Moles or nevi are growths of pigmented cells. They can be benign moles, shown on the left, or melanoma on the right. And melanoma is the deadliest type of skin cancer. It can grow de novo, or it can arise from previously benign moles. Unlike moles, melanoma is locally invasive and can metastasize. And melanoma is a relatively common skin cancer with high incidence and mortality. According to the World Health Organization, across all cancers worldwide, melanoma ranks number 17 with about 300,000 new cases per year, and number 22 with about 58,000 deaths per year. And melanoma is more common in people with lighter skin tones. The majority of cases and deaths occur in Europe, North America, and Asia. For example, there are about 110,000 new cases and 8,700 deaths per year in North America. In the United States, melanoma is the 6th most common cancer. Screening patients for melanoma is a two-step process. So patients examine their own skin at home, or they see their primary care physician in the office, who then examines them. If the risk of melanoma is high, then the patient is referred to a dermatologist. And dermatologists often use a special type of magnification called dermoscopy, with up to 10 times magnification to decide whether a biopsy is needed. Of note, these are not corresponding images. And a 2008 meta-analysis study showed that dermoscopy increases melanoma screening sensitivity from 71% to 90%, but has minimal impact on specificity, which is around 80 to 90%. And so screening melanoma by direct visual examination at 1x magnification generally involves the ABCDE criteria and the ugly duckling sign. So moles with asymmetry, border irregularity, color variation, large diameter, and evolution over time are more concerning for melanoma. And moles that are ugly ducklings or different from the other moles on a patient are also more concerning. And so patients with these types of moles should be referred to a dermatologist for additional screening. And so at the dermatology office, they use dermoscopy to check for certain specific imaging features. And these features include atypical pigment networks, peripheral streaks shown by the arrows on the left, a blue whitish veil, also in the image on the left, atypical globules shown in the box on the right, and atypical vessels shown by the arrows on the right. And concerning moles under dermoscopy are then biopsied. So after melanoma is biopsied, then it's staged to determine how severe it is. And melanoma staging primarily involves depth, but also the presence or absence of ulceration. The deeper that melanoma has already invaded on biopsy, the more likely it is that the melanoma has spread to other parts of the body. So stages 0 through 2 are localized, stage 3 has spread to regional lymph nodes, and stage 4 has spread to distant areas. So survival for melanoma depends greatly on the disease stage at diagnosis. Survival rates are excellent if melanoma is localized on diagnosis, so almost 100% at 5 years, but quite poor if melanoma has spread to other parts of the body, around 35%. Thus, although diagnosing melanoma is very important, diagnosing melanoma as early as possible is critical. Unfortunately, access to dermatologists for speedy diagnosis and treatment can be quite difficult, especially for individuals with certain levels of education, socioeconomic status, and types of insurance. This figure shows the impact of different levels of education on survival over time in Sweden, with lower education leading to decreased survival. Similarly, this figure shows the impact of lower socioeconomic status on survival over time in patients in California. And this last figure, or two figures, shows the difference in survival for patients who have Medicaid, which is the public insurance for patients with lower incomes in the United States, and uninsured patients relative to non-Medicaid patients, such as commercially insured patients. And much of the survival differences for all three of these factors are thought to be related to delays in diagnosis and treatment. So through MoleCheck, we wanted to address this issue of access to a primary care doctor or dermatologist for melanoma screening. And hopefully, this currently leads to delayed detection and worse survival rates. So at-home triage of moles with MoleCheck may help patients decide when to seek screening by a doctor, potentially leading to earlier detection of melanoma and improved survival rates. So how does MoleCheck work? So MoleCheck helps adult patients outside of healthcare settings classify magnified photos of their pigmented skin lesions as concerning or benign and decide whether to monitor or immediately follow up with a doctor. MoleCheck was built with MIT App Inventor and does require both an Android phone and a phone microscope lens shown on the right. So regarding the front end to use MoleCheck, you first have to set the disclaimer and then go to the home screen. If you select the option to take a photo of your mole, the camera function activates. You confirm your photo, and the app triages the photo as benign, intermediate, or malignant. A benign result recommends additional monitoring. If you select the option to load a photo from your phone, the photo library opens, you select the photo, and the app triages the photo in the same way. Indeterminate or malignant results direct the user to follow up with a doctor. So how does the code on the back end work? The back end was built with MIT App Inventor code blocks that are quite intuitive. One code block each was used to define the actions when each button is pressed, when the camera takes a photo, or when the user selects a photo. And calling the image classification model, interpreting the result, and error handling were also handled by separate code blocks. The cutoffs for the probability of being benign was set to 45% or less for being malignant or concerning for cancer, 45 to 55% for being indeterminate, and above 55% for being benign or reassuring against cancer. For image classification, we used the MIT App Inventor component PIC, or Personal Image Classifier, to do transfer learning on the convolutional neural network MobileNet to classify photos. The PIC component was trained using images from the International Skin Imaging Collaboration, specifically 1,200 images of nevi and 2,000 or so images of melanoma, all pre-processed and split into training, validation, and test data sets. The trained PIC model had modest sensitivity and specificity, around 75 to 80% for detecting melanoma. So here's a short demo of the mobile app. First, you open the app, then you accept the disclaimer, then you press the take a photo button, and the light, the camera needs to be on. You take a picture, you confirm, and it will give you an evaluation. The other way to use the app is to load an image from the phone. So you can load an image, and it will evaluate that as well. So there were a few limitations that we noted while developing our mobile app. The ISIC images are primarily of people with lighter skin tones, so the app doesn't classify as well skin lesions with darker background skin tones. To simplify the data set for this prototype, we excluded other non-cancerous skin lesions and other skin cancers, so the app would not be able to classify those. The classification output was somewhat sensitive to lighting, focus of the image, and angle of the photo. The magnifying lens cost about $40 USD, which may be prohibitive for some patients. And the sensitivity and specificity were modest, raising concerns for a high false positive rate in the setting of low prevalence of melanoma. And so for next steps, these include incorporating training data sets with darker skin tones, expanding training data sets to other benign skin conditions and skin cancers like squamous cell carcinoma, fine-tuning the classification thresholds for the benign, indeterminate, and malignant results, and comprehensive user testing to optimize both the classification accuracy and the user interface. Thank you for listening to our presentation. Any questions?
Is it available for iOS?
Not currently. So one of the design choices we had was trying to design for Android, design for iOS, or both at the same time. There are some issues with the pick component in terms of using it on the iOS. So right now it's not available for iOS. It's also not available for anyone to use right now. Technically, this would be a medical device, so we would need a lot more studies for this.